There's a kind of body fat you cannot pinch, cannot see in a mirror, and cannot find on a bathroom scale. It sits behind your abdominal wall, packed in around your organs. And in a study that followed more than 15,000 American adults for about 14 years, men with a completely normal body mass index who carried their fat centrally had a higher risk of dying than men with the same body mass index who did not. Same weight, different place. So the question everybody asks is the obvious one: can you target it? Last time we covered blood pressure and the habit that lowers it. This time it is the fat you cannot see, and I promised you 3 things: why it behaves differently from the fat you can pinch, whether you can actually target it, and what genuinely shrinks it. We are going to answer the targeting question directly in the middle of this video, not at the end, and every number comes from the trial that produced it. Chapter 1. What you cannot see. Start with where it actually is, because almost everybody pictures this wrong. Picture a cross-section through your midsection. First, there is skin. Under it, a layer of fat you can hold between your fingers. That is subcutaneous fat, and it is the fat everybody means when they talk about belly fat. Then comes the abdominal wall, the muscle, and behind that muscle, in a compartment you cannot reach, sits your liver, your intestines, and fat packed into the spaces between them. That is visceral fat. 2 different tissues in 2 different rooms, separated by a wall of muscle. Here's what makes it worth a whole episode. In a cohort study published in the Annals of Internal Medicine in 2015, researchers followed 15,184 American adults for about 14 years. A man with a normal body mass index of 22, who carried his fat centrally, had a hazard ratio of 1.87 for death from any cause, compared with a man at the same body mass index without central fat. The 95% confidence interval ran from 1.53 to 2.29. That is for men specifically. And I want to be careful with what that means. It is an association measured across a population, not a prediction about you. But it does tell you something important. The scale is not measuring this. So how would you know? Honestly, at home you get 1 crude marker, and I am going to tell you exactly how crude it is. The federal guideline threshold from the National Heart, Lung, and Blood Institute is a waist over 40 inches for men and over 35 inches for women. Measured with a tape at the level of the top of your hip bone at the end of a normal breath out. But a tape measure cannot tell visceral fat from the fat under your skin. Only a CT or MRI scan measures it directly. What the tape gives you is a risk marker, not a diagnosis. Chapter 2, why it is different. And this is the part that surprised me, because the answer is not really about the fat. It is about the plumbing. Every fat cell in your body releases things into the bloodstream. Fatty acids, glycerol, signaling proteins. Where that blood goes next is the whole story. Fat under your skin drains into your general circulation and gets diluted across your entire body before it reaches anything important. Visceral fat does not. Visceral fat drains into the portal vein, and the portal vein runs directly into your liver. So whatever visceral fat releases arrives at your liver first, undiluted, before the rest of you sees any of it. And researchers have actually measured this in people. In a study published in the journal Diabetes in 2007, surgeons drew blood from the portal vein and from an artery in the arm in the same patients during surgery. The interleukin-6 concentration, an inflammatory signaling protein, was about 50% higher in the portal vein than in the arm, and the portal vein level tracked with C-reactive protein in the general circulation, a standard inflammation marker, at a correlation of 0.54. Now, the honest caveat: these were 25 people with severe obesity, sampled during bariatric surgery, because that is who you can take a portal vein sample from. Do not read the size of that gap onto yourself. Read the direction. So picture the consequence: a steady delivery of fatty acids and inflammatory signals arriving at the one organ that sets your metabolic thermostat. The liver responds the way any tissue does to a flood of fat it did not ask for. It starts storing some of it inside its own cells. Researchers call that ectopic fat. Fat in a place it does not belong. And a liver carrying fat handles insulin less well, which pushes blood sugar up, which pushes the whole system further in the same direction. And this is where the two fats genuinely diverge. Measured side by side, visceral fat tissue secretes more of several inflammatory messengers than subcutaneous fat does. Interleukin 6, interleukin 8, monocyte chemoattractant protein, 1, TNF-alpha. It also secretes less leptin, the hormone that reports how much energy you have stored. Same body, same person, two fat depots, two different chemical outputs. Which is why this shows up in the risk data as its own thing. The reviewers put it plainly, visceral fat dysfunction contributes to increased cardiovascular disease risk, independent of total adiposity. Independent means it is not just standing in for how much fat you carry overall, it is carrying its own signal. So that is the difference, not a different substance, a different address with a direct line to your liver. Now the question you actually came here for, Chapter 3, can you target it? Sit-ups, crunches, every ab routine ever sold. Does working the muscle underneath do anything to the fat around it? The cleanest test of that was published in the Journal of Strength and Conditioning Research in 2011. 24 sedentary adults randomized. Half of them did 7 abdominal exercises, 5 days a week for 6 weeks. Their diet was held constant. At the end, there was no change in abdominal fat, no change in abdominal circumference, and no change in body fat percentage. Working the muscle did not move the fat sitting on top of it. But I'm not going to tell you the case is closed because it is not. In 2023, a small randomized trial in physiological reports took 16 overweight men, matched the total energy they burned, and had one group do abdominal work alongside their running. That group lost more trunk fat over 10 weeks than the running-only group, even though total fat loss was similar. It is 16 men, it is one trial, and here's the detail that matters most for us. Their scan could not tell visceral fat from subcutaneous fat, so it cannot answer our question at all. So here's the honest answer to the question in the title. Delivered on time, you cannot choose the spot. Nothing in the evidence lets you point at one part of your body and pull fat off it on demand. And the one trial that hints otherwise could not even see the tissue we care about. But there's a second half to that answer, and it is much better news. You do not have to choose the spot because visceral fat appears to respond more readily than the fat under your skin. Fat cells in the visceral compartment show a stronger response to the signal your body sends during exercise. That is the leading explanation, not settled fact. But the trials line up behind it, and that is what the rest of this video is about. Chapter 4, what actually shrinks it? And we start somewhere unusual with what happens if you do nothing at all. Duke University ran a trial called Starred-Eyed. 175 sedentary, overweight adults randomized for 8 months with no change in what they ate. One group was the control, which means they carried on exactly as before. Over those 8 months, the control group gained visceral fat. 8.6% more with a p-value of 0.01. Not because they did anything wrong, because they did nothing, and nothing is not neutral. Now the exercise groups in the same trial, walking about 11 miles a week was enough to stop the accumulation. Not reverse it, stop it. The group that jogged about 20 miles a week did reverse it. Visceral fat down 6.9%, subcutaneous fat down 7.0%, and again, no change in calorie intake. The author's own conclusion was that a modest increase over the standard public health exercise recommendation produced significant decreases in visceral, subcutaneous, and total abdominal fat. And notice the size of those standard deviations. Individual results varied enormously. And that no diet change detail is not a one-off. A meta-analysis in PLOS-1 in 2013 pooled 15 studies and 852 people and deliberately included only exercise programs with no dietary intervention at all. Pooled effect size, minus 0.497 with a confidence interval from minus 0.655 to minus 0.340 and a p-value under 0.01, translated into something you can picture, across the 5 trials that used a standard imaging measure, 12 weeks of exercise cut more than 30 square centimeters of visceral fat in women and more than 40 in men, without changing what anybody ate. The same analysis found something worth knowing before you plan your week. There was a threshold for intensity. Moderate and high-intensity aerobic exercise produced significant reductions. Low-intensity training did not. So the walk matters, but the effort inside the walk matters too. So which kind of exercise? The largest comparison we have is a network meta-analysis published in Obesity Reviews in 2024, pooling 84 randomized controlled trials and 4,136 people. Its finding is refreshingly unfussy. Aerobic exercise at moderate intensity or above, resistance training, the two combined, and high-intensity intervals were all beneficial for reducing visceral fat. In the probability ranking, vigorous aerobic exercise and high-intensity intervals came out most likely to be effective. One caveat worth naming, this newer analysis found combined training helpful, while the 2013 one did not. When two analyses disagree, I lean on the larger and the newer. Nothing here says stop lifting. One food finding because it is unusually clean. In a controlled trial in the Journal of Clinical Investigation in 2009, overweight adults drank beverages sweetened with either fructose or glucose, supplying a quarter of their daily energy for 10 weeks. Both groups gained a similar amount of weight, but visceral fat volume rose significantly only in the fructose group. Same calories, same weight gain, different destination. Two important limits. A quarter of your daily energy from a sweetened drink is an experimental dose, far above what most people drink. And this is about sugar-sweetened beverages at that dose, not about eating fruit. Chapter 5, your week. Here's how to use all of that, and we start with who should check in first. This episode's advice is to move more, at a moderate effort or above. That is safe for most people, and it is not automatically safe for everyone. If you have known heart disease, uncontrolled high blood pressure, diabetes, or you have been sedentary for a long stretch, talk to your doctor before you step the intensity up. Nothing in this video is a diagnosis, and a tape measure is not one either. If your waist reading concerns you, that is a reason to book an appointment, not a reason to start a crash diet. Now the week itself built only from what the trials actually did. The stride result came from about 11 miles a week to hold the line and about 20 miles a week to move it. In practical terms, that is roughly 30 minutes of brisk walking most days at the low end and around 45 minutes of jogging or an equivalent effort 4 times a week at the high end. Intensity is the lever the 2013 analysis flagged, so whatever you pick, it should be brisk enough that talking gets a little harder. And per the 2024 comparison, keep your resistance training. It is on the beneficial list. And measure, because this is the one number the bathroom scale will never give you. Tape at the top of your hip bone, level all the way around, snug without compressing, at the end of a normal breath out. Same time of day once a month written down. You are not looking for a good number on a chart. You are looking for your own trend, and you are bringing that trend to your doctor. So you cannot choose the spot. You do not have to. Move at an effort that makes talking a little harder. Keep lifting, watch the sweetened drinks, and let the tissue that responds fastest do the responding. Next time we go inside a different silent one. Sleep apnea, the signs that are worth mentioning to your doctor, and what it does to your heart. Subscribe so you do not miss it. The fat you cannot see is not a verdict on you, and it is not a moral failing. It is a tissue with an unlucky postcode and a direct line to your liver. It is also, by the look of the evidence, the tissue that answers first when you start moving. So do not go looking for it in the mirror. Go for a brisk walk and let the part you cannot see be the part that changes.